left ventricular systolic function is probably one of the more important things that we do as a intensivist in the ICU. I think, I don't have data to back it up, but I think after vascular access and maybe volume assessment, function assessment is probably something that we do most frequently. So it's good to know all the ways that we can assess it and what are the barriers and pitfalls. And also, I reiterate this to the fellows. The only way to get good and competent and comfortable in it is to keep doing it, and do it even in patients who don't have low cardiac, you are suspecting depressed function, because that's how you would know what normal looks like. So we'll go ahead and get started. So we'll start with a case. A 5-year-old girl admitted to the ICU from an outside ED for respiratory distress at the middle of the night. Chest X-ray is not available, but reported as prominent interstitial markings, questionable pulmonary edema. Patient is hypotensive, 80s over 40s, slightly tachycardic. Just about making it with saturations 91% on 80% FiO2 on high flow, and the history is that she's not been eating or drinking well for the past couple of days. So you obtain some focus images. This is the apical 4-chamber view. Then we have a parasternal short axis and a parasternal long axis view. Let them run for a minute. Let's go to the options. So what's the next step? Give some fluid bolus for hypotension and tachycardia. Call cardiology for an urgent echo. Treat for pneumonia with antibiotics, and order a routine echo tomorrow morning. I'll wait here for 5 seconds, or maybe 10 seconds. All right, we'll move on. So this is the outline of the talk. We'll talk about the basic views. We'll do some slides on qualitative assessment, and then quantitative measures, and lastly, a little bit about stroke volume measurements. One of the disclaimer I have is I am, although I'm a pediatric intensivist, I have training in cardiac ICU. Most of what I learn about echo or POCUS is from adult courses, and as my preparation for the critical care echo board. So some of my presentation has an adult training bias, and there are subtle differences between the adult POCUS and pediatric echo, which I will explain as we go along. So basic views. So the first thing that we do when we start doing an echo is a parasternal long axis. This is a relatively easy to obtain view. The probe is on the left sternal border, second or third intercostal space, the marker pointing towards the patient's right, and it provides good assessment of the left ventricle, mitral valve, aortic valve, and right ventricular outflow tract. It's also good for assessing the function. And then from here, you rotate the probe 90 degrees. So the marker is pointing towards patient's left shoulder, and you obtain the parasternal short axis view. This is at the papillary muscle level. And it's very good for assessing the function, relative sizes of the right ventricle and the left ventricle, and the septal positioning. We'll not go into too much details on how to obtain this. There is a whole separate talk on basic views. So we'll just give a brief introduction. And then after that, we move to the apical views. Apical views are great for assessing the relative size of right ventricle and left ventricle. Also the mitral valve and the tricuspid valves and their regurgitation, stenosis, putting Doppler pulses on them, as well as the size of the chambers. And then from there, you can just point the probe upwards to obtain a apical 5-chamber view, which is for the left ventricular outflow tract assessment. as well as the aortic valve and also the mitral valve. Then you will go to the subcostal long axis. Sometimes it depends on the patient's habitus and what else is going on in the chest. Sometimes you might be able to obtain very good subcostal images. Sometimes you aren't. Generally, children's we can obtain better subcostal images than adults. And as it's often told to the cardiology fellows, you can do the whole echo from just subcostal views. And this is the image obtained from the Echo Atlas, pediatric Echo Atlas. So, and this is what I have obtained during a focus view. You can see a little difference in the orientation. The pediatric echoes are always flipped like this, and adults or ED obtain it in the same plane, but here you see this as a right atrium, right ventricle, left ventricle, and left atrium over there. And then I've rotated it to so that it looks like a short axis view also here. Okay, so moving on to LV function. So what actually is the LV function? So the most part, mechanistically, it's the ability of the left ventricle to change its size and shape from a diastole to systole. That's what we are measuring. And we can measure this qualitatively or quantitatively. So qualitative LV function, and when you go to these echo courses, I remember one of the instructors telling us that qualitative function doesn't come before quantitative function. It is more difficult to assess the function qualitatively than quantitatively, just because you need a trained eye to assess it. And you need to look at a lot of normal echoes before we can say whether this is a depressed function or hyperdynamic function or mild or moderate depression. Now, there are some things that you can help in making that assessment, and you can ask certain questions. One is, do the walls thicken and the chamber size diminish during each contraction? Do the mitral valves open briskly? And in the parasternal long axis, does the anterior leaflet appear to touch the septum? And then the chamber dilation of the atrium of the ventricle. So looking at this top image, we can see that the walls thicken during contraction. The chamber size of the left ventricles becomes small. The mitral valve is open very briskly, and the anterior leaflet seems to be touching the septum during each contraction, and there is no dilation of either chamber. Or looking at the one in the bottom, the walls don't seem to thicken at all. There's a lot of motion going on, but not a whole lot of actual decrease in the size of the left ventricular cavity. And the mitral valve is opening, but not briskly. And look at the distance between the anterior leaflet and the septum. So that's a severely depressed function. So we haven't talked about quantitative measurement yet, but there are some of the pitfalls and barriers of the LV function assessment. In quantitative assessment, you are measuring, so it's important that we need to be able to see the endocardial border. So endocardial dropout will lead to an overestimation of the volume, because it will include that all in the cavity. And foreshortening, being an off axis, that can make your chamber size appears very small, and that can do underestimation of the volume. We'll go over that when we go into the quantitative assessment. As far as qualitative assessment, it's important to know the heart rate doesn't change anything. It just makes it appear that it's a more contractility than it is. So tachycardia causes overestimation. When the heart is beating slow, we tend to underestimate. And also the valvular regurgitation will make you overestimate. So the MR will cause overestimation of contractility or ejection. So what are the categories of qualitative assessment? This you will see in the echo report. There are 5 categories: hyperdynamic, normal, mildly depressed, moderately depressed, and severely depressed. Sometimes the cardiologist are political for the cardiac surgeons, and they would say like mild plus or moderate plus or severe minus. But generally, that's how you would report these. So depressed LV function. So how do we characterize left ventricle? So we have seen this. This is normal, and this is severely depressed function. Mild and moderate depression is hard to say with a qualitative echo, but this echo was called by my cardiologist as a moderate depression, and it appears to be brisk, and that is a lot of it is just because the heart is beating too fast. But you can see the cavity is not diminishing as much as we would like it to be, and the walls are not getting thickened. Okay, so there is another pitfalls, and this is more important for an intensivist, is echo is sort of a portrait at one time, but point of care echo is something that you do repeatedly, and we also are aware of the whole patient and not just the function as you assess on the echo. So you need to see what the how the loading conditions are, what the preload is, what the afterload is, what the heart rate is. For example, preload, when the patient is dehydrated, the heart function will appear, the ejection fraction will appear high. So a patient who lives at home with a ejection fraction of 35% becomes dehydrated, gets admitted to the hospital, and now his ejection fraction would come up to be like 50%. So remember, preload can impact it. Other shock mechanisms can impact it. Sepsis can cause you to be vasodilated, so the heart will appear to be functioning normally. However, it may not be functioning to the extent that is needed for the amount of vasodilation or shock. So you have to be aware of all those things. And also, now this is more important for adult, is the regional wall motion abnormality, so regional or global LV dysfunction. Okay, hyperdynamic function. So this is what would be called as a hyperdynamic function. Now, again, as we talked earlier, the hyperdynamic function can be just because of too much contractility. So use of inotropes can do it. Hypertrophic cardiomyopathy can do it. But in a non-cardiac patient, sometimes just sepsis or anything that causes a decreased afterload can make the heart function look like this, and also decreased preload, bleeding, mitral irritation, they can also cause function to look hyperdynamic. So finding suggestive of hypovolemia. Now, volume status assessment is a completely separate talk or series of talks. But sometimes you will see an echo report by a cardiologist say that the heart looks underfilled. And so you can assess just by an echo whether or not the heart is underfilled. And for that, both the ventricles need to look small. And the left ventricle is small and it should be hyperdynamic. Should see like the kissing papillary muscle that we see earlier, and IVC is small and collapsible. But again, volume status assessment with an echo has this problem that it works very well in extremes, and it works at extremes where sometimes you can get clinical assessment also that the patient is dehydrated or fluid overloaded. It's where the clinical assessment is dubious, is where you require a lot more skill to assess with the echo whether the patient is, what the volume status is. Okay, quantitative measures of left ventricular function. So this I have adopted from Lopez in 2010, a very good article, sort of an essential read for cardiology fellows on measurement in pediatric or congenital echoes. So if you want to assess the left ventricular systolic function, we have two things. We can assess the pump function, which is the global chamber performance, and we can assess the myocardial function, which is the performance of the cardiac myofibers. Now, this is sort of what we are after when we are assessing the contractility, but it's hard to do. There are ways to do it. It's a velocity of circumferential fiber shortening, which has to be adjusted to heart rate and end systolic wall stress. The good thing with this kind of assessment is that it's independent of loading conditions. while pump function that we've been talking about is all dependent on loading conditions, dependent on preload, afterload, and the heart rate. So it is dependent myocardial force generation as well as the loading conditions. And pump function, we can assess two ways. We can assess it, there are some geometrical measurements of it, and then there are non-geometrical measurements of it. Non-geometrical measurement is the DP and DT. This is by Doppler. So you see the mitral regurgitation Doppler tracing, and then see the time it takes for the speed to go up from 1 meter per second to 2 meter per second, and that's DP or DT. And then there are some, and I think in adults, less than 1,000 is considered a depressed function. Normal is more than 1,200. And then tissue Doppler indices like the S wave. Now, we're not going to talk about non-geometric functions as well as the myocardial as a load independent function in this talk. But if you're doing, say, like critical care boards and stuff, then they're all fair game, and they will ask you questions on all of these. What we talk about is the geometric functions, and geometric, as the name suggests, involves some sort of measurement of the geometry. It can be the linear measurements as well as area measurements or the volume measurements. So shortening fraction, fractional area change, as well as ejection fraction fall under the geometric pump function measurements, and they are the most commonly utilized. They're great. They're easy to measure. They have a lot of reproducibility. The only problem is they're all load dependent, which is fine for our case because focus, and that's the utility of focus. We can do these things repeatedly over the course of illness, so you can see how the patient is trending. And we are also aware of every different organ system or whole body's current state to make an assessment. So cardiac measurements, this is again Lopez. This is important. Each measurement, because of the various ways you can cause errors in the measurement, should be done in at least two views. And measurement of intraluminal dimension should be done from one inner edge to the opposite inner edge. And then the vascular dimensions and the vascular diameter should be measured at the moment of maximum expansion. So mitral valve, tricuspid valve should be measured in diastole, and aortic valve, pulmonary valve in systole, and all arteries should be measured in systole. Now you also need to define what end diastole is and what end systole is. So end diastole, in diastole, the mitral valve opens, blood flows into the left ventricle, and then it ends, the mitral valve closes, and the aortic valve opens when you go in systole. But there is a period when just preceding the mitral valve closing is the end diastole. So mitral valve is still open, but the next frame the mitral valve will close. So that's the end diastole. And end systole, in systole is when the aortic valve is open and the blood is flowing into the aorta, and then the systole ends when the aortic valve closes and the mitral valve is going to open. So the frame just preceding the mitral valve opening is the end systole. Now you can do it with an echo and just slow it down while you are taking the measurements. It's a little bit easier on the echo machine because they have a little ball but in at least the Sonosite machine that I use is a little bit challenging because you have to use your finger on a scroll bar. And also echo machines generally have EKG attached to them, so the EKG is also running. And so end diastole is when the QRS appears, and end systole is when the T wave appears. So that makes it a little bit easier. But these are important things to know when you're doing the measurements. Okay, so linear measurements are of three types: fractional shortening, MAPC, and E-point septal separation. We're concerned about fractional shortening, but we'll touch a little bit about on the MAPC and the EPSS. So what is fractional shortening? Fractional shortening is just the math is pretty simple. Left ventricular end diastolic diameter minus left ventricular end systolic diameter divided by left ventricular and diastolic diameter. And normal is more than 30%, and when it is less than 20%, it's severely impaired. Where do you measure it? Now, adults recommend parasternal long axis view. And why is that? Is because in parasternal long axis, you can draw the M mode, and you can make sure that the measurement is on the perpendicular to the long axis of the ventricle, which you can do with the parasternal long axis. But Lopez recommends it to be done in parasternal short axis in pediatrics. So in the congenital heart echoes, it's always done in the parasternal short axis. And some of the reasoning is that in parasternal short axis, you have multiple points where you can do the diameters, while in parasternal long, it will just be one. And so wherever you can have the clear distinction of the endocardial border, you can draw the line. Also, as opposed to adult, congenital echoes recommend that we do it in 2D rather than in the M mode. Because in M mode, you can draw the line and it will show you, it's very easy to trace it, but it's hard to know where the endocardial borders are on that. So it's easier to do it in parasternal long axis sometimes with the M mode, but the recommended is to do a parasternal short axis. Limitations are the same as, one of the limitation is the same, it's all load dependent. So all of these have this problem of load dependency, but it's also measuring at one point, so it assumes no regional wall motion abnormalities, and less valid with abnormal septal motion, bundle branch block, right ventricular volume overload, and it's reflecting only the radial, but not the longitudinal shortening. So again, this is from the Otto's textbook of echo, which is the adult echo Bible. You drop it perpendicular, so you can see the measurement is perpendicular to the long axis or perpendicular to the septum here. And you can do it in the parasternal short axis also, and in the M mode, you measure end-diastolic diameter and systolic diameter. And this is from the Lopez book. Basically, you measure it from here to here, inner edge to inner edge, and you can do it in diastolic diameter. You measure it at the QRS. And this is what I've done. Again, I've done it in adult manner. You do a parasternal long axis view, and you just drop a M mode cursor there and measure the diastolic diameter and the systolic diameter, and the machine has the built-in software to calculate this. So it will calculate the fractional shortening, which is 37%, and it will also calculate a ejection fraction for you. Now, ejection fraction from a shortening fraction is basically just one measurement. It calculates the ejection fraction, and it's used some regression formula. It's called the Tycholz ejection fraction. You would actually see it in the echo report from cardiology, ejection fraction, and it says ejection fraction Tycholz. So that's what it means. It is less reliable, of course, because there's a lot of assumptions going on here. It's a symmetrical heart with no regional wall motion abnormalities. Measurements are centered and perpendicular to the border, and it's an ellipsoid heart. So take it with a grain of salt, but it's there if you can't do the ejection fraction by the Simpson's method for any reason. Most of the time, it's because you can't get a good four-chamber view. So what about MAPC? Now, TAPC, or tricuspid annular systolic exertion, is a very well-recognized measure of left or right ventricular function in adults. Not so much MAPC. Even for adults, MAPC is considered like crappy, but you can do it. And the idea is the same. You take a four-chamber, and then you drop in M mode at the medial annulus of the mitral valve, and then you calculate the exertion. And anything more than 12.5 is considered to be normal, or at least not more than mildly reduced ejection fraction. Then E-point septal separation. Now, again, in pediatrics, it's not used as much, and the reason is every heart would have a different size. So you will need to use the Z-scores for that. But the idea is very simple, is that the mitral anterior leaflet is supposed to touch the septum when it flunks open. And so the distance between the septum and the anterior leaflet of mitral valve can give you an idea on how the function is and how depressed or how dilated the heart is. And E-point septal separation of more than 7 millimeter is associated with severe left ventricular dysfunction, ejection fraction less than 30% in adults. So measurement is fairly easy. You obtain a parasternal long axis view, and then you drop an M mode at the mitral leaflet, and you will get this sort of mitral valve click. And then you measure this distance, and here it is 8 millimeters. So it's suggestive of a depressed function. So you can see it's kind of a depressed function. So E-point septal separation, good to know, but not entirely used that much in pediatric ward. Again, fractional area change, it is the same principle, left ventricular end diastolic area minus left ventricular end systolic area divided by left ventricular end diastolic area, and normal is 35 to 65, and you measure it in parasternal short axis at the papillary muscle level. So coming to the volume assessment, volume measurements are basically you want to measure the end diastolic volume and then end systolic volume, and then you subtract the end diastolic and systolic volume from end diastolic volume divided by end diastolic volume, and that will give you an ejection fraction. And these are the commonly recognized cutoffs. 52% to 74% is normal. And 75% and above is hyperdynamic function. So 52 and 74 is normal. 41 and 51 is mildly depressed. 30 and 40 is moderately depressed, and less than 30% is severely depressed. Now there is I think a little bit of difference between male and female, but the number to remember is 52%. So 52% to 74% is normal. 40 to 50 is mildly, 30 to 40 is moderately depressed, and less than 30% is severely depressed. So how do we calculate the volume? And that's appears complicated, but it's really it's very basic. What they are doing is they're assuming this cavity of the left ventricle is a collection of small discs, and each of this disc is just it's a small disc, so its volume is going to be pi r square h, and then you just add them up, and you do it in 2 times. You do it in 4-chamber view, and then you rotate it, and you measure it, cut the heart in 2-chamber views, and then you can do it in diastole, both of them, and then in systole. So you do in apical 4-chamber, you measure in diastole and systole, and then you do an apical 2-chamber view and measure this in 4-chamber in diastole and systole, and that's how you get the biplane ejection fraction. The big problem with that is that you get to obtain a good 4-chamber view, and it should not be foreshortened, and you should have a good visibility of endocardium. And there is another method which I have not used, but it's mentioned in the Lopez's article. It's basically trying to measure the volume of the heart using this formula, 5/6 short axis basal area. So you measure it in the short axis, in the parasternal short axis. Here it is being measured in the subcostal view, but you measure the basal area, and then you measure the left ventricular length, and there are very specifications on where to draw this line, and you measure the left ventricular length. So you do this in diastole and systole, and that's how you will get the ejection fraction. So this is how we do it in the point of care. So you obtain a 4-chamber view, and then now it appears complicated, but the machine again has a software built into this. So all you need is a good 4-chamber view, and then you go into the measurements, and then you go into the volume assessments, ejection fraction measurement, and then you frame shift and measure for the diastolic dimensions, and then the machine will auto populate this area for you. You have an option of dragging this to align it with the endocardial borders where you want it to be, and then you do it for the systole. Again, this is created for you by the machine, and then you can drag these points to make it fit. And then when you measure these things, it will give you a ejection fraction. So here I've only done the apical 4-chamber ejection fraction, 44%, but you can do ejection fraction 2-chamber, and then it will automatically average it out and calculate a biplane ejection fraction. So again, just to reiterate that point, it's very important that the loading conditions, it's a complex variable, and there is important to recognize the impact of the loading conditions, preload, afterload, and mechanical ventilation also. So that's, again, it's an advantage for an intensivist because we can do this many times as opposed to a cardiologist who can do it, at the maximum 1 time a day. Okay, so lastly, we'll talk a little bit about stroke volume measurements. Stroke volume measurement is also very useful. It's very useful when you want to see if giving volume to a patient is making an impact in increasing the cardiac output. To do that, we need to be able to measure the stroke volume. And the idea is that the stroke volume is a cylinder of the blood ejected from the left ventricular outflow tract in each systole. So if you think of a cylinder, the volume of a cylinder is pi r square h, and you need the radius of the, so to do this, we only need 2 things. We need the radius of the left ventricular outflow tract, and we need the height of this cylinder, which is the VTI of the left ventricular outflow tract. And the cardiac output is just the stroke volume and the heart rate. So again, this is a little cylinder in the left ventricular outflow tract. Every time the heart contracts, it pushes that cylinder out, and all you need to know is the volume of this cylinder. So how do you do it? You obtain a parasternal long axis view, and you zoom in or decrease the depth to focus on the aortic valve, then freeze the image with a fully open aortic valve and measure the diameter of the aortic valve annulus. Then heart rate, now echo machines are hooked down to the patient monitor, and they have the EKG running, so they have the heart rate automatically. They pull the heart rate in point of care ultrasounds. Also have, some of them have the option of hooking to the monitors, but you also have an ability to manually enter the heart rate. Okay, the other important thing to measure is the VTI. VTI is actually very useful in isolation also. All you have to do is to obtain an apical 5-chamber view and then drop a pulse wave Doppler with a sampling volume just proximal to the aortic valve, trying to keep the pulse wave Doppler parallel to the flow of the blood, and then you obtain the a pulse wave, and then you would, now this one you have to actually, at least in sonocyte, you have to draw it by hand, but you just trace the border of the VTI. Now this is going away from you, so that's why it's below the line, and that's the VTI. What is VTI in adults? It's very easy because they have one number to remember. So in adult, a VTI of less than 10 is considered low VTI. It's a good repeatability, and you can assess the left ventricular systolic function under varying preload inotropes and heart rate. And VTI is just the velocity, that is centimeter per second, times the time, so that it becomes actually the unit of that is just a centimeter. So this is how we can measure it. So we get a zoomed in view of the aortic valve. This is just a sonocyte machine, and then you measure it, and then you obtain a apical 5-chamber view, and then you drop a pulse wave Doppler. As long as you can get a good pulse wave signal, white on the outside, dark on the inside, and clear crisp envelope, you can measure it. Also important to remember the little valve clicks that you can see sometimes. And what you want to measure, it's the LVOT and not at the aortic valve level, because that will give you a higher number. So if you see a lot of valve clicks, you have to come back on it, just pull the sampling volume down a little bit, and then you will get the LVOT. And if you measure this, then the machine will automatically calculate the VTI. Here it's 9.13. And once you have the VTI, you can calculate the stroke volume, and then actually the machine will calculate the stroke volume also for you, and then you can calculate the total cardiac output if you put in the heart rate. So we'll end this with a question again. A 5-month-old boy is admitted to the ICU at 2 a.m. for respiratory distress. It's always at 2 a.m. He's rhinoenterovirus positive. Chest X-ray had prominent interstitial markings. He was started on continuous albuterol because somebody in ED heard some wheeze. When he arrives to the ICU, he is hypotensive, 60/30. Heart rate is 170. Saturations were 94% on 60% high flow at 8 liters per minute. And you are a good focus operator, so you do focus on every patient and you obtain some focus images. And this is the heart, a parasternal shot. This is your parasternal long axis view. And you also obtain a IVC variability. What's your next steps? The same, you would give fluid bolus for hypotension and tachycardia. You will call cardiologist for an urgent echo. You would start giving him antibiotics, and you would prepare to intubate and start invasive mechanical ventilation. I'll give 10 seconds. I'll end this again with a just one slide on the use of echo in shock. Echo is all about pattern recognition. So when we do echo, it's always best to be very systematic on an echo. Do all the images, and do it the way it is done by a cardiologist. Obtain the images, and then go back and evaluate those images and do your measurements. Don't try to interpret at the same time while you're doing the echo. Also try to make yourself as comfortable as you can while obtaining the echo images. Do it the way echocardiographer does it. Position yourself comfortable, bring the patient to your height. Try to move the patient, put the right side up around 45 degrees so that you can push the heart towards the left, so you can obtain the best possible images, especially in patients who are you have the slightly obese patients. You would have problems with mechanical ventilation because mechanical ventilation will expand the lungs and the heart will get squeezed. In those patients, you might have to use subcostal. Subcostal, it might help to ask the patient to bend the legs because that will soften your abdominal muscles and maybe help you obtain better images. Try to be as try to spend remove all the distractions. So if there are EKG stickers on the chest, don't try to move yourself around the EKG stickers. Move the EKG stickers so that you can obtain the best possible images. Also try to be ambidextrous in echo, because you cannot always say that I'm going to use my right hand for the probe, because sometimes you may end up that you are not able to use your right hand for the probe. So cardiology fellows are always taught to be ambidextrous in trying to use the echo probe. Again, the echo is risk-free. It doesn't harm the patient, but wrong interpretation is the biggest risk. So be very wary of the wrong interpretation. And the only way of getting competent is to do it again and again, and do it in a mentored fashion. Or somebody else is doing QAs on your images. And again, only when we have obtained the best possible image should we perform the interpretation. So avoid this natural inclination of trying to interpret at the same time you are doing. So obtain the images, go back, do the measurements, and then interpret it. Always use more than one view in measurement. So even if you're measuring like a TR velocity, you don't just measure TR velocity at one place. Do it in multiple TR views and measure it. And definitely ejection fraction and contractility should be done in more than one views. Always measure ejection fraction and report it to your attendings or cardiologist, so that people also know that you know what you're talking about. So 4 P's: patient, probe, protocol, and the picture. Thank you.